Hello and welcome. I'm Diane Lavinia, Director of Industry Relations for the IDSA Foundation. We're excited to have you all join today as we commemorate the end of C. difficile Awareness Month, a final webinar with two excellent speakers to discuss how the microbiome can defend against C. diff and other infections. This webinar is made possible by the support of our Platinum industry partner, Ferring Pharmaceuticals. Please visit our website, idsafoundation.org, to access prior webinars, sign up for our monthly newsletter, follow us on social media, and stay informed about the mission-critical work of the foundation to reduce the burdens of infectious diseases. Before I tell you a little bit about our first speaker, I'd like to invite our attendees to enter questions at any point during the program using the Q&A button. Let's begin. Dr. Tina Chopra is a professor of medicine in the Division of Infectious Diseases at Wayne State University and the corporate medical director of hospital epidemiology, infection prevention, and antibiotic stewardship at Detroit Medical Center, Wayne State University. Her research interests include epidemiology of healthcare-associated infections, infection prevention, antibiotic stewardship, and immunization. Dr. Chopra has published over 80 papers in various journals and book chapters. Additionally, she has independently reviewed over 60 journal articles. Dr. Chopra has a special interest in immunization and studying the epidemiology of infections, including C. diff and multi-drug resistant organisms. Dr. Chopra has championed the mammoth task of leading the COVID-19 pandemic from Wayne State University and DCM. She is serving on the President's COVID Task Force and on the President's Public Health Committee. She has appeared on countless media and print interviews, including CNN, Fox, NPR, and Time Magazine. Dr. Chopra?
Thank you, Diane, for the very nice introduction, and thank you to IDSA for hosting this webinar. With this, I would like to share my screen. So like Diane mentioned today, along with my colleague, Dr. Paul Foyerstadt, we will be talking about Clostridioides difficile and microbiome. And without much delay, I would like to go over the learning objectives for my talk. I would like to discuss the role of microbiome in overall health. What is a healthy microbiome? Explore the relationship between gut microbiome, pathogenesis of C. diff, and cycle for recurrence, and also address the rates of healthcare-associated gastrointestinal infections caused by C. diff. Last but not the least, I would like to discuss the use of antibiotics in recurrent C. diff. So, Clostridioides difficile, as the name indicates, it's a very difficult organism, difficult to diagnose, difficult to treat, difficult to prevent. It is an unusual organism that has become a nuisance disease, and the most common cause of hospital-acquired diarrhea, and also an urgent threat to our community. It is also known as C. diff. It's a gram-positive, rod-shaped, spore-forming organism. It's an anaerobe. An unusual thing about it is in the pathogenesis, it produces a toxin. It produces toxin A and toxin B, which are highly, notorious in causing the inflammatory diarrhea that C. diff patients present with. And the symptoms, it's a spectrum. They range from completely asymptomatic to very severe disease, severe diarrhea, life-threatening diarrhea. Patients can present with sepsis. They can undergo colectomies because of diarrhea and even death. As I mentioned, we are facing this huge epidemic of C. diff, and based on the current numbers, CDC has labeled it as an urgent threat, very similar to some of the very other severe infections like multi-drug resistant organisms, drug-resistant gonorrhea. C. diff it's not just a nuisance disease, but it causes huge number of cases, as high as 224,000 of cases hospitalized every year, and more than 13,000 deaths annually, amounting to more than 1 billion healthcare costs. So the threat level as labeled by CDC is urgent with this. And this data is from 2017. So we are in 2022. The numbers have only gone up. And this level of threat is based on several criteria, which basically tell us that how a disease can be a major public health threat. But C. diff infections have gone up, between 2011 to 2014. It accounts for more than, in 2011, it accounted for 12% of healthcare associated infections, whereas in 2015, it accounted for more than 16% of all healthcare associated infections. And if you look at all GI infections, it accounts for about 70% of all GI infections. So as you can see, different kinds of infections here, including all hospital-acquired infections, including pneumonia, surgical site infections. If you look at all gastrointestinal infections, C. diff is a major cause of all GI infections. And these are the orange bars are showing you the infections in 2011, whereas the blue ones are showing you in 2015. And you can see the comparison here. So it was the most commonly reported pathogen overall. Now, if you look at hospital-acquired C. diff and you look at community-acquired C. diff, overall, if you notice, the prevalence of community C. diff has actually stayed the same. It stayed high. If you look at this data, this was published in New England Journal of Medicine, and it's striking to see how between 2011 to 2017, the rates of community onset C. diff have stayed high. Invariably every patient that I see with recurrent C. diff coming from the community has been exposed to antibiotics like outpatient clinics for a viral infection or at a dentist's office. All of these are very high risk factors for presenting with C. diff and then presenting with recurrent C. diff, which I will talk about shortly. And recurrent C. diff, if you have the first recurrence, the chances of second and third recurrence, they keep going up. And that is the biggest problem with recurrence. As you can see here, this is the indexed episode of a patient with C. diff presenting with sepsis in the blue bars and having a colectomy, which are very severe outcomes when you think about C. diff, a diarrhea patient with diarrhea presenting with ending up with sepsis or ending up with a colectomy or ending up dying because of that. And this data is actually very compelling. Thanks, this data has been published by Dr. Foyerstadt and very, very compelling, showing how with every recurrence, the incidence goes up. It almost doubles with first, second, and third recurrences. And this is the worst outcome that is possible in these patients. So it becomes a vicious cycle. Of course, in addition to the risk factor, the biggest risk factor that I mentioned was antibiotics, which can disturb the microbiome, which I'll talk about shortly. But remember, other risk factors include in advancing age, older adults are immunosenescent, which means that they don't mount up the same antibody response to the toxins produced by C. diff. So they are more likely to, have recurrent C. diff. In addition to antibiotics, immunosuppression, residing in a skilled nursing facility, exposure to PPIs, all of these are risk factors for recurrent C. diff. And like I mentioned, after the first episode, the chances of recurrence, they increase. They become, in general, recurrent C. diff, the prevalence is about 25 to 50%, depending on the type of population, but then it doubles. It becomes 50%, even as high as 60% in our nursing home population. Like I mentioned, the cycle of C. diff, this is showing you a normal microbiome. These are the thousands of species that reside within our gut, predominantly, composed of diverse variety of species. But when we have exposure to antibiotics or any of these stressors that I mentioned, there is loss of this good bacteria. The colonization resistance is lost and you enter into a dysbiotic state. which makes the microbiota more susceptible to organisms like C. diff. And as these spores, they enter our GI tract, they germinate, and these vegetative forms produce toxins. And this is the result of the toxin is, this inflammatory diarrhea. It may get cleared in some patients where there is only asymptomatic colonization, which is also, there is no disease with the colonization, but it is, the patient can still spread C. diff. Or in other patients who have C. diff, they may clear their infection completely and develop a normal microbiota and recover, or they enter into this vicious cycle of recurrence where they're never able to restore that microbiome that I am talking about. So this is a very nice visual representation of how this, cycle exists, and also how patients enter into this vicious cycle of recurrent disease where their microbiome is disrupted and they enter into a permanent state of dysbiosis. Now, like I mentioned, what is the gut microbiome? It is highly diverse organisms which live in our intestinal tract, about 100 trillion organisms with more than 1,000 species, which are, all of them are very, very, more diversity is there, better health is there. So what are the important functions of our gut microbiome? They help us with immunity. They help us maintain an epithelial barrier. They prevent, they help us with colonization resistance. They prevent colonization of organisms like C. diff. In talking about immunity, there is a link between COVID as well as the healthy gut microbiome as well. And a lot of patients of COVID presented with co-infections with C. diff. Again, highlighting the importance of immunity that is built by this gut microbiome. So normally, we are in the state of eubiosis, where we have a very good diverse microbiome, which is established through a good healthy diet, which is diverse, composed of fruits, vegetables, high amount of fiber. And we have abundance of these good bacteria, which include Bacteroides and Firmicutes. But whenever we have exposure to, our diet is not good, or we are exposed to antibiotics, we are exposed to chemotherapeutic drugs, steroids, any stress that can disrupt the microbiome, and we can enter into dysbiosis, where we'll have less of these Bacteroides and Firmicutes and have more of proteobacteria, for example. And that is the state that is not permanent. We can come back to the eubiotic state, but in some patients, this cycle becomes quite permanent when they enter into the cycle of recurrent C. diff, and it's very hard for them to establish that normal microbiome. And this is what I will show you here in this slide. For example, these are all bacteria, like I was mentioning. This is a normal patient, normal control, with abundance of diverse microbiome, which includes Bacteroides, Firmicutes, and less of proteobacteria. But when they have C. diff, their microbiome starts getting disrupted, and they have more of those bad bacteria and less of the diverse bacteria that we all need to maintain a good state of eubiosis. And here is a patient with recurrent C. diff, and you can see that they have a lot of proteobacteria. They have less abundance of your Bacteroides. And this is a dysbiotic microbiome. And this is what happens when we are exposed to antibiotics, when there is a lot of dysbiosis, and the patient enters into a permanent state of dysbiosis, and a vicious cycle of recurrence begins in these patients. Now, we talk a lot about antibiotics disrupting the microbiome. This is the rate of recurrence with concomitant antibiotics. And this patient has no exposure to antibiotics, and their recurrence rate is 16%. But in exposure to antibiotics during treatment, the recurrence rate is 31%. Exposure to antibiotics in 3 months post-treatment, it goes up as 48%. And you would think, even with C. diff, we treat C. diff with antibiotics. They can also disrupt the microbiome. So really, the answer here is what Dr. Paul Foyerstadt will take you through and talk about how we can restore this microbiome. With this, I would like to give it over to Diane. Thank you.
Thank you, Dr. Chopra. Our second speaker, Dr. Paul Foyerstadt, is a native of, excuse me, a native of Long Island, New York, and attended the University of Pennsylvania, where he earned his BA in biology with distinction in research and graduated summa cum laude. Dr. Foyerstadt attended the Weill Medical College of Cornell University in Manhattan, where he earned his MD degree, and stayed at New York Presbyterian Hospital, Weill Cornell Medical Center for his internship and residency in internal medicine. Following completion of his residency, Dr. Foyerstadt moved on to the Montefiore Medical Center in the Bronx for his clinical fellowship training. Throughout Dr. Foyerstadt's training and practice, he has been actively involved in research and other academic pursuits. His areas of interest include chronic diarrheal syndromes with a specific focus on C. diff infection, the microbiota, ischemic diseases of the gut, and the eosinophilic disorders. He has presented his research extensively at national meetings and has authored and co-authored many manuscripts, textbook chapters, and online modules. Another passion of Dr. Foyerstadt's is teaching, frequently giving lectures locally, regionally, and nationally, and also mentoring the fellows in the Division of Digestive Disease at Yale New Haven Hospital, where he holds a clinical appointment as an assistant clinical professor of medicine. His clinical practice at the PACT Gastroenterology Division is his ultimate passion, filling the majority of his work time as he sees a broad spectrum of patients with gastrointestinal and hepatic disease. Dr. Foyerstadt is affiliated with the St. Raphael campus of Yale New Haven Hospital, Yale New Haven, and the Milford campus of Bridgeport Hospital. Dr. Foyerstadt?
Thank you. I think I was on mute. So I'm going to thank the IDSA so much for inviting me to speak. It's such an honor to be here. Tina did such a wonderful job walking us through the epidemiology of C. difficile. She spoke to us about the pathophysiology. She spoke to us about the microbiota. I think it's important, as I was charged with a couple of different things. One is looking at the microbiota, I think from a little bit of a different standpoint, which is associating it with modifiable and non-modifiable risk factors, and then supplementation of the microbiota and the way that we can use that to reduce future recurrence. So to start off, I really want to take us through a broad overview of treatment of C. difficile. And we know that any treatment of C. difficile starts with an antimicrobial. And the IDSA has done such a wonderful job with their updated guidelines in 2021, focusing on the best data for antimicrobial treatments, favoring fidaxomicin, vancomycin being an acceptable alternative, and really shifting metronidazole lower down in the treatment algorithm. But it's so important to realize that these antimicrobials, they control the vegetative phase. They control the phase that releases toxins that stimulate symptoms. This is why when our patients are on antimicrobials, they feel well. But as any clinician knows, when we pull off that antimicrobial, fairly frequently, we're going to get that call that they're recurring. Why is that? That's because of what Tina was alluding to before, which is this state of dysbiosis, an altered microbiota. And that altered microbiota leaves us susceptible to recurrence because it's the microbiota that gives the spore phase that knockout punch. So when we think about C. difficile infection, it's important that we realize that recurrence is really high. It's unacceptably high. Overall recurrence rates are estimated to be about 25 up to 35% with initial infection, 40 to 50% with first recurrence, and up to 50 to 60% with second recurrence. So what are some risk factors that leave our patients at risk for recurrence? And these risk factors apply for both initial infection and for recurrent disease for the most part. I like to think of them into three groups: demographics, medication exposure, and environment. From a demographical standpoint, age over 65, female gender, any form of immune compromise, chronic kidney disease, HIV, inflammatory bowel disease, diabetes, medication exposures. These are things that we as clinicians give to our patients that leave them susceptible to this. And the classic medications, of course, are the antimicrobials: amoxicillin, ampicillin, clarithromycin, fluoroquinolones, cephalosporins, piperacillin tazobactam, recently added to this high-risk list. But I'm a gastroenterologist. And as a gastroenterologist, we use a lot of acid suppressive medications such as proton pump inhibitors and histamine blockers. So why are they associated with C. difficile infection? Classically, we think about basic immune system functions. What is the first line of defense of our immune system? Actually, if you think about it, it's probably our skin. What is the second line of defense of our immune system? Largely, it's believed to be our gastric acid. Anything we swallow, our gastric acid should neutralize or sterilize. However, when we reduce that gastric acid, more things gain access to our body. And that is essentially the theory behind why we thought initially proton pump inhibitors were associated with an increased risk of initial C. difficile and an increased risk of recurrent C. difficile. But in 2015, like many things in science, we were thrown a little bit of a curveball. Very simple study, looked at a group of healthy 20-year-olds, characterized their microbiota before proton pump inhibitor and then after proton pump inhibitor usage. And you know what? There were increases in enterococci and streptococci and decreases in Clostridioides. Plainly stated, actually the microbiota became dysbiotic and left patients prone to C. difficile as a result of that. Now, environmentally, yes, this is a risk factor. Do individuals live in skilled nursing facilities? Do individuals spend significant amounts of time in the hospital? Why? Well, if you think about it, who's living in a skilled nursing facility? Who's spending significant amounts of time in the hospital? People that have the other risk factors, the demographical and the medication exposures, and you're surrounded by people who potentially have C. difficile itself. Now, when I think about risk factors, it's important that I characterize them into modifiable, things that I can have an impact on, and non-modifiable. And the non-modifiable risk factors actually can potentially have an impact on our microbiota. So I'm going to walk us through a couple of quick studies that look at this. The first looks at age. This was a Japanese study that looked at 100 individuals aged 20 to 25 and compared them with 200 individuals aged 65 and above. They compared their microbiota, and it turns out in the older group, there were higher levels of Escherichia. In the younger group, there were higher levels of lactobacillus. So age matters. And this is something that we can't change, but there is a significant difference. And this probably contributes to risk for C. difficile. Gender, unfortunately, also matters. This is a very nice Ukrainian study, looked at 2,301 individuals, broke them up into male and females, and compared them. Overall, the women had higher levels of Firmicutes, higher levels of actinobacteria, lower levels of Bacteroidetes, and a higher Firmicutes to Bacteroidetes ratio. Once again, we see differences, and this might potentially explain why women are more susceptible to get C. difficile than men. Ethnicity also matters. This is a nice study that looked at African Americans compared with Asian Pacific Islanders, compared with Caucasians, compared with Hispanics. And there were statistically significant differences with regards to the microbiota with all of these individual ethnicities. Interestingly enough, within the ethnicities, there were also statistically significant differences for age, for gender, and for body mass index. So we can see, and again, another non-modifiable risk factor that could potentially leave people at risk for C. difficile infection. But it's not all doom and gloom. There are modifiable risk factors that we can help our patients change. Now, there isn't a ton of data in this space with regards to C. difficile, but diet can actually change our microbiota and do it in a relatively short period. This is a very nice study that looked at a cohort of individuals who had a baseline, quote unquote, healthy diet. They had a run-in period where they characterized the microbiota, and then they were randomized to one of two arms, either a high animal protein diet or two, a high vegetable protein diet. They were on that diet for 4 weeks, and then there was a 6-week follow-up. And they looked at changes in the microbiota. And it turns out in the animal protein-based diet, there were increases in bile salt tolerant microorganisms and decreases in Firmicutes. That's incredibly interesting. Why is that interesting? Because form, fit, function, even in a 4-week interval, we had higher levels of bile salt tolerant microorganisms. Bile salts are needed to digest fats. Animal proteins are high in fats. The microbiota adapted. Firmicutes are classically associated with digestion of vegetable proteins and fiber. Lower levels of Firmicutes, there were lower levels of vegetables in the diet. So we see an adaptability of the microbiota in a way that we can possibly impact change. Now, what I alluded to before is that the standard of care antimicrobials, they have an impact on the vegetative phase of C. difficile, but we know that recurrence rates are incredibly high. So what can we as clinicians do to alter that trajectory and reduce those rates of recurrence? Well, form fits function. What we can potentially do is restore that microbiota, restore those deficiencies, restore the Bacteroidetes and Firmicutes that are deficient, that leave patients prone to recurrence. Otherwise, on their own, as Tina showed within the Drukanja study, patients have to regrow their microbiota. And if they regrow their microbiota, there can be missteps, and that leads to recurrences. So this is data that looked at the foundational clinical trials considering fecal microbiota transplantation, the rudimentary approach to supplementation or restoration of the microbiota. And the first study we're going to talk about is a study by Van Nood, published in the New England Journal of Medicine, now almost 10 years ago. What did they show? An overall efficacy of a nasoduodenal transplant of 81.3%. This study was stopped at interim analysis due to futility of the vancomycin arm. Fecal transplant was superior. Importantly, within this trial, they looked at the diversity of the microbiota in the donor pre-transplant and in the recipient post-transplant, and they showed that the diversity was recovered. The more diverse the microbiota is, the healthier it is. And after this, there was a whole slurry of other studies, peaking in about 2017 with a meta-analysis by Qureshi. Within that meta-analysis, they looked at 30 retrospective case series, 7 prospective trials. The efficacy was 92%. Many people like Tina and I thought we were putting ourselves out of business. But like many things in science and in life, better structured studies give us a better idea of efficacies. And that's what we see here with this meta-analysis by Racine Tariq, Sahil Khanna, and Daryl Pardee. They said, look, we now have some data, but we have better structured studies. Let's look at studies that have a basic premise, a control group. And when they included a control group, they looked at 13 studies, 610 total patients, and found an efficacy of 76.1%. Not quite that 92%, but still excellent. But when they drilled deeper and they looked at open label studies had an efficacy of 82.7%. Randomized control trials, the gold standard for us as clinicians, 67.7%. Now, these trials, the foundational studies, were essential, they were important, but they used rudimentary methodologies, donor-directed screening, physician-directed screening. There was heterogeneity with regards to the efficacy endpoints, the safety endpoints. There was heterogeneity of the products themselves. There was no universalization of these things. And as a clinician, what we're really driving towards, what we're looking for are treatments that have a predictable safety and efficacy profile, treatments that we can quote data for that specific treatment to our patients to ensure comfort on both sides that what we're doing is safe and effective. And this takes the form of products called LBPs, or live biotherapeutic products. Live biotherapeutic products is the moniker that the FDA uses for FDA overseen forms of microbiota replacement therapy. What I'm showing you on this slide are 4 products in the pipeline. The top 2 have finished phase 3 trials, RBX 2660 and SCR 109. The bottom 2 have finished phase 2 trials, CP 101 and VE 303. So let's quickly run through these products and their primary data. Now, as we do this, you'll notice that the clinical trials have certain similarities. They're all prospective, they're all multi-centered, they're all randomized, they're all placebo-controlled. They all require a standard of care antimicrobial beforehand. All of them had an 8-week follow-up for recurrence, and all of them had at least 24-week assessment for safety. The first product we're going to talk about is RBX 2660. RBX 2660 is a broad consortium. It has a wide array of microorganisms, including both spore and non-spore forming bacteria. There's 10 to the 7th microorganisms per cc. This is rectally administered as a single administration of 150 cc's. And what I'm showing you here is the ultrastructure of the PUNCH CD3 trial, the phase 3 study considering RBX 2660. Within this study, patients with 1 or more recurrence of C. difficile all received a standard of care antimicrobial. There was then a washout period, randomization to either RBX 2660 or placebo, followed for 8 weeks for recurrence, 24 weeks for safety. Now, within this analysis, a specific type of statistical analysis was performed called a Bayesian analysis. A Bayesian analysis is an analysis that grows the number of participants in a study if there are similar study structures. So the PUNCH CD3 trial, the phase 3 trial, had a similar structure to the phase 2 trial considering RBX 2660. Similar patient populations, the same product, similar diagnostics, similar efficacy endpoint, similar safety endpoint. If the signal of efficacy in the placebo arm and the signal of efficacy in the intervention arm, RBX 2660, were within specific bands, you could leverage the data, grow the study, and have a harder statistical analysis. And that's what was done. The overall efficacy for RBX 2660 was 70.6% versus 57.5% in the placebo arm. And this product is being considered by the Food and Drug Administration currently. Another product is SER-109. SER-109 takes a different approach. The Chang study that Tina pointed to showed that there were deficiencies of two major phyla, the Bacteroidetes and the Firmicutes. SER-109 says, well, maybe we don't need to give a wide array of microorganisms. Maybe we just need to give Firmicutes spores. This product is sourced from human donor stool. It is then taken through an ethanol purification process, isolating just Firmicutes spores, putting it in an encapsulated form. It's administered as 4 capsules daily for 3 days, following a standard of care antimicrobial, and dosing is 3 × 10⁷. What I'm showing you here is the structure of this phase 3 trial, the EcoSpore 3 trial. Within this trial, patients with 2 or more occurrences of C. difficile all receive a standard of care antimicrobial. They then have a washout period, receive magnesium citrate, and then are randomized to either SER-109 or placebo, followed for 8 weeks for occurrence, 24 weeks for safety. And what I'm showing you here is the data that was published in the New England Journal of Medicine earlier this year. Within this assessment, SER-109 had an efficacy of 88% versus 60% in the placebo arm, a statistically significant difference, and this product also is currently being reviewed by the Food and Drug Administration. CP101. This product has now gone through a phase 2 trial and is enrolling in a phase 3 trial. CP101 takes a broad approach. They say, let's use a wide array of microorganisms in an encapsulated formulation. It is used as 10 capsules on a single day following a standard of care antimicrobial. The dosing is 60 × 10⁻⁻⁻ bacteria in a single administration. Now, the PRISM-3 study, which was a phase 2 trial, included patients with 1 or more recurrence of C. difficile, all received a standard of care antimicrobial, had an antimicrobial washout period, and then the patients were randomized to either receive CP101 or placebo. 8-week follow-up for efficacy, 24 weeks for safety. This is the primary efficacy endpoint for the PRISM-3 trial, showing an efficacy of CP101 of 74.5% versus 61.5% in the placebo arm, a statistically significant difference, and this product has now entered a phase 3 trial, which is currently enrolling. The final product that we're going to talk about today is VE303, which takes a different approach as well. VE303 uses 8 bacterial strains that were originally isolated from the human digestive tract and then synthetically reproduced within the lab. It is administered in an encapsulated form, and I'm showing you here the phase 2 dose ranging study that was presented at Digestive Disease Week earlier this year. Within this study, patients with 1 or more recurrence of C. difficile all receive standard of care antimicrobial. They are then randomized after a washout period to a high dose of VE303, 10 capsules daily for 14 days, a low dose, 2 capsules daily for 14 days, or placebo, followed for 8 weeks for recurrence and 24 weeks for safety. The low dose arm didn't meet statistical significance. However, the high dose arm did, with an efficacy of 86.2% for VE303 versus 54.5% in the placebo arm. So this product will also likely proceed to a phase 3 trial. Now, one thing that you will never see me do is put all these studies on one slide, because that's not fair. It's not fair because the studies have different designs and the studies have different inclusion criteria. So what are some important factors that we need to think about when we consider these studies as clinicians? 1, what was the duration of the standard of care antimicrobial before the intervention? Longer durations, probably more damage to the microbiota, but also more likely to eradicate C. difficile. The number of episodes of C. difficile, more recurrences, probably a more dysbiotic state. The diagnostics. We didn't cover diagnostics today, but suffice to say that the majority of people participating understand that the PCR assay has a tendency to overdiagnose C. difficile. By overdiagnosing C. difficile and having those patients included in clinical trials, you might not actually have a patient with C. difficile, and you can't expect the treatment to work. So diagnostics play a key role in the inclusion within clinical trials and how we contextualize the information that we take from those clinical trials, the washout period. Tina alluded to this earlier, but remember, treatments like vancomycin, yes, they are effective against C. difficile, but they also alter the microbiota. By altering the microbiota, they actually leave us prone to a recurrence of C. difficile. This is why there's a difference between fidaxomicin recurrence rates and vancomycin. But the same needs to be held for when we use treatments like live biotherapeutic products. If vancomycin is still around in our system and we use a live biotherapeutic product, it might destroy some of the goodness there. So we need to make sure that the washout period is within a sweet spot where enough vancomycin is out of the patient's system, but also the patient hasn't fully recurred as yet. Whether or not a bowel purge was included. And finally, the dosing. So I've covered a lot of information over the last few minutes. We spoke about modifiable and non-modifiable risk factors. We spoke about the impact of those risk factors potentially on the microbiota and things that we can and can't change. And then finally, we spoke very briefly about antimicrobials controlling the vegetative phase of C. difficile. We focused more on the spore phase eradication through the microbiota and microbiota restoration. We spoke about foundational clinical trials, but we spoke about the next generation of live biotherapeutic products. 2 products are currently being reviewed by the FDA, RBX 2660 and SCR 109. 2 other products are currently one is enrolling in a phase 3 trial, CP 101, and one is setting up potentially a phase 3 trial, VE 303. The future is incredibly bright in this space with regards to C. difficile management, but it's probably going to be a 2-phase management scheme with standard of care antimicrobials followed by potentially a live biotherapeutic product. And with that, I'll say thank you so much for your attention, and I'll kick it back to Diane.
Thank you. And thank you to both Drs. Chopra and Foyerstadt for your insightful presentations. We're now at the Q&A portion of our webinar. There is still time for audience members to enter questions using the Q&A button. I'll now turn it back over to both doctors to provide answers.
Thank you, Diane, and thank you, Paul, for such a spectacular presentation. Maybe, I did answer a lot of questions, but there are a few questions, Paul, I think if you can address a couple of them. One of them is if you could comment on probiotics.
Okay. So probiotics are a really important hot button topic. Everyone likes to talk about them. I think it's important, we spoke a bit about the live biotherapeutic product concept. It's so important to understand that LBPs, or live biotherapeutic products, have gone through FDA overseen trials. So they potentially will be considered drugs, but they won't be drugs. The term for them will be live biotherapeutic products. Probiotics are supplements, and as such, they have not been brought through widespread clinical trials. So the only time the FDA gets involved with probiotics is if there is questions with regards to safety and or efficacy associated with them. So with that being said, there is not a ton of data associated with them. There are 2 major position papers that have been put forward in the last couple of years. One was in Gastroenterology in August of 2020. It looked at probiotics in general for multiple disease states, but specifically for C. difficile, the statement was that the certainty of evidence is insufficient to make a recommendation for probiotic usage for primary prevention or for prevention of recurrence. The American College of Gastroenterology guidelines made similar statements in May of 2021. Now, it's important, though, to contextualize that, look, probiotics, for the most part, are safe. There are certain circumstances where I wouldn't use them. Which probiotic would I consider using? The probiotic that I would consider using is Saccharomyces boulardii. Saccharomyces boulardii has very nice basic science data looking at the bile salt milieu, the metabolomic effect. Remember, when we spoke about the microbiota restoration, we just spoke about the bacterial phyla, and we spoke a little bit about the changes, but we care what those changes impact on the metabolic environment, and Saccharomyces boulardii seems to inhibit recurrence of C. difficile. So if you're going to choose one, that would be the one to think about. We need to be careful, though. We do not want to use probiotics in patients who are significantly immune compromised, patients who are in the intensive care unit, and also any patient that receives microbiota restoration therapy or fecal transplant. Because in those patients, the probiotics can either be dangerous or compete for resources where the good microorganisms would be depleted as a result.
Thank you, Paul. This was great. Somebody has asked if C. diff recurs within 1 to 2 weeks while off of oral Vanco or Fidaxo. How do we define this condition? I can take this. I mean, you still define it as recurrent C. diff. There are variable definitions for recurrence. Most commonly accepted ones are 8 weeks or 2 months after the first one. So this would be labeled as recurrent C. diff. And, Paul, there's a next question is specifically for you. And they would like to know if you've had 2 recurrences of C. diff in full transparency, which treatment would you prefer? RBX 2660 or SER 109, and why?
Okay, so that's a bit of a loaded question. I think both treatments have excellent validity. I wouldn't choose one over the other. I think the best treatment is what's most accessible to patients. And I think that's been really the bigger problem over the last few years, especially with the COVID-19 pandemic. The availability of microbiota replacement therapy largely fell off a cliff. And my hope is that with these live biotherapeutic products, these treatments will become more available to a much wider population and many more clinicians would be comfortable using them. So my answer to that question is the best treatment for the patient is the one that's most accessible to them. And I believe it's important, as I pointed out, to contextualize some of the differences in the structures of those clinical trials and use your own clinical judgment based on that.
Thank you, Paul. Paul, can you comment on precision medicine versus FMT?
I'm not 100% sure what is meant by precision medicine. Tina, are you maybe?
I'm thinking probably they are referring to phage therapy or which, as we are all familiar, there is taking a lot of importance in the recent world with a lot of data and literature around personalized phage therapy. But I don't know of any data in particular for C. diff in that case.
Okay. No, I completely agree. The concept of precision medicine, at least that as I understand it, is you're right. It would be more targeted type of therapy. I think that what's important to understand about these live biotherapeutic products and fecal transplant in general is with C. difficile, we understand what's deficient and we understand what we want to supplement or restore. In a lot of other disease states, we don't. And unfortunately, we put the cart before the horse about 10 years ago when we understood with C. difficile essentially what was happening from the Chang study. Well, we said, well, why don't we just start using this treatment for everything? And we didn't use the basic scientific pathway, which is define problem, then try to solve problem.
Absolutely, Paul. Somebody wants to know if they can have access to presentation materials. I think that would be for IDSA to answer. Another question is asking with regard to effectiveness of real poop versus industrial poop consortia in restoring the gut health.
Okay, so real poop versus industrial poop. This is an interesting one. I've gotten a lot of questions with regards to this throughout the last few years, but this is a good one. So look, here's the deal. The real poop would be what I used to do previously, maybe 4 or 5 years ago, which is I have a patient with recurrent C. difficile. I ask them if they have a friend or relative that they can talk to on a very honest basis, or I would call them on a very honest basis and explain the situation. I'd screen them for maybe 20 or 25 things. I would screen them through a blood donor questionnaire to make sure that there aren't any major red flags. If they were eligible, they would come in the day of the colonoscopy. I would have them donate. They'd have a bowel movement on site because there were reports of people bringing in not their own stool or non-human stool. And the patient would bring in a blender. We would take 250 or 500 cc's of normal saline. We would blenderize it with about 100 grams of stool. I do a colonoscopy and put as much of the material in as possible. Ended up being about 300 cc's. That is sort of the real poop. I would say that the industrial is safer. And that's really the most important element here. The industrial has gone through much broader screening from both a donor health screening standpoint, but also from a quality standpoint of the stool itself, and also the proportions of what's within the sample. Meaning that, with something like SCR 109, they're just isolating Firmicutes spores. They're taking everything else out, right? With RBX 2660, they're giving a broader consortium of both spore and non-spore forming bacteria, but they're also looking at the proportion of microorganisms so that it's within a specific band, so there's consistency of therapy also. So the real poop, I don't think will have the consistency of efficacy, but also more importantly, the consistency with safety that these live biotherapeutic products will have. And CP101 and VE303 are other examples also. I don't want to leave them out.
Absolutely. I totally agree with Paul. I think the safety is extremely important, particularly with reports of recent, MDROs, ESBL infections. The screening and safety is extremely important. And I think hence the importance of, agents like RBX 2660. Now, early C. diff recurrence rates are around 20%. What do you think of recent studies have shown a greater recurrence rate? So yes, I think I'm happy to answer this. And Paul, if you want to add something, prevalence of recurrence rates, it's anywhere between 25 to 50%, depending on what population we are dealing with. Recurrence rates are much higher, around 50% and even 60% in nursing home patients. So yes, recent reports do show a greater recurrence rate because we are seeing a lot of recurrences in our nursing home population. Also what Paul had shown you in the data. Also, if a patient is in the ICU, the recurrence rates are as high as 50%, once they have ICU admissions. So there is data around both of those categories. Paul, anything to add?
Yeah, no, I completely agree. Look, the reality of the matter is recurrence rates are somewhat dictated by what we're using, right? One of the key elements in the IDSA guidelines update from last year that Stu Johnson put forward and colleagues really speaks to this nicely, which is if you're using fidaxomicin initially, you're going to have a lower recurrence rate. And this is even 10 years, 11 years after the primary data was published. Because despite all this time and some of the evolution of C. difficile, the trials still consistently show a lower recurrence rate. So when you use a rule of thumb, standard of care, fidaxomicin, vancomycin, you're probably looking at about a 30 to 35% recurrence rate with initial infection, and then you're going up from there. And I think the 60% with multiply recurrent is accurate because it's much more challenging at that point for the microbiota to restore itself through natural growth processes. And this is where supplementation comes in.
Absolutely. Another question is role of prophylactic PO vancomycin or Bezlo.
Okay.
Go ahead, Paul, if you want to take it.
Sure. So a couple of great questions there. One is, we can talk about bezlotuximab in one sec. Prophylactic vancomycin has been a somewhat controversial topic over the years because we alluded to this already, right? Vancomycin is a very effective treatment for C. difficile. The problem with vancomycin is that it has some collateral damage. So it destroys some of the microbiota that's there that's good to prevent recurrence. With that being said, as a solitary treatment, it is very, very effective. The question, though, is, look, you have a patient with multiply recurrent C. difficile. You finally get them cured. They're finally doing well. And then they call you 8 weeks later. They got to go to the dentist and they're getting clindamycin. What do you do there? Is there data to support using vancomycin for secondary prophylaxis? And the answer is yes. And that data came largely from a meta-analysis by my friend and colleague Sahil Khanna. And he essentially showed that there was a statistically significantly lower rate of recurrence if a low dose of vancomycin was used. So if somebody receives 1 day of clindamycin from a dentist, you give 1 day of vancomycin, 125 milligrams, twice for that day. UTI for 3 days of treatment, 3 days of 125 BID of the vancomycin, and that should lower rates of recurrence. The next question that logically would come up from this is, well, how long do you do that for? I typically do that for about 6 months afterwards. After that, I think that the microbiota is as stable as it's going to be and the regrowth processes have occurred. Now, with regards to bezlotuximab, that's a completely different area. So bezlotuximab, of course, is a fully humanized monoclonal antibody that binds toxin B in a specific manner. By doing that, it decreases the inflammatory processes associated with the toxins of C. difficile, and it's associated with decreased rates of recurrence. Within the 2 pivotal trials, the Modify 1 and Modify 2 trials, the number needed to treat to reduce 1 recurrence was 10. The number needed to reduce 1 recurrence in a over 65 population was 6. Now, bezlotuximab is given at the same time as the standard of care antimicrobial. Why is that? Because it's an infusion. It needs to cross the mucosal barrier of the colon. Well, when a patient has active C. difficile and they're being treated with antimicrobials, the tight junctions are more open, and therefore, theoretically, the bezlotuximab gets better access to the lumen of the gut. That's what the theory was, and that's what the FDA indication says. But what we've seen in post-approval studies is that actually bezlotuximab seems to work well even after completion of standard of care antimicrobial. And in clinical practice, sometimes it's hard to get a patient bezlotuximab while they're on the standard of care antimicrobial. The other piece that I'll say about bezlotuximab is that in the last couple of years and last couple of months, we've seen a lot of great data with regards to this, because as I alluded to earlier, the COVID-19 pandemic largely shut down access to fecal transplant for a lot of providers, and they still needed something to help reduce recurrences, and the bezlotuximab took that form. And we've seen very consistent data with the pivotal Modify 1 and Modify 2 trials. So now bezlotuximab prophylactically, I've never seen data for prophylaxis with bezlotuximab. Given its mechanism of action, I wouldn't think that it would be effective, but it's certainly something that would lead me to scratch my head and think a little bit further.
Thank you, Paul. The next question is what do you do for a patient who doesn't want a fecal transplant? I can take a stab and then Paul, your experience. But, for me, most of my patients who've needed fecal transplant, 100% of them have agreed to get it. Remember, fecal patients with recurrent C. diff are really, their lives are disrupted. Their quality of life is really gravely affected. They cannot do day-to-day activities. I've had young patients who've lost their jobs, and it is very, very disruptive to their normal functioning. Most patients in my experience have begged to get a fecal transplant, especially during the pandemic. Things have been so hard, yet we haven't had the ability to do it, and patients have been suffering a lot. So there haven't been issues. If patients have questions, it's very important to address those questions, to listen to them, to tell them the exact procedure. How are we going to do it? What product are we going to use? It all depends on how comfortable we make our patients. And I think that is the key to a successful fecal transplant. Paul, please go ahead.
No, I completely agree with everything you said. I don't have really anything significant to add to what you said.
Thank you, Paul. And then the other question was, why can't we just do a rectal installation? Why a fecal transplant? Why an FMT and not just a rectal administration? So in my opinion, like you were mentioning, it has to reach the product has to reach the gut, the area where, C. diff is very prone to cause its disease. The pathogenesis is restricted to the large intestine. We want to make sure it reaches that site. Yes, people have done traditionally, they have done rectal installations, but the data that we have is with FMT, and it's with good, successful data. Paul, anything to add?
Yeah, I mean, I'm not sure 100% understand the question. I think FMT is a very vague term, and that's part of one of the things that we're working through right now, which is what really is an FMT. An FMT could be, according to the Van Noot study, which is a nasoduodenal installation of liquid stool. Well, here in the United States and probably globally, I don't know if that's going to be very well received as kind of a broad application for large groups of patients. We have capsule formulations, and the capsule formulations have shown excellent efficacy, as I alluded to earlier, not in the foundational space, but I alluded to them with regards to CP101 and FCR109 and VE303. And then we do have RBX2660, which is a rectal installation. And I think that all of them have had consistent efficacy and safety profiles. So I think that as we move forward and hopefully we get FDA approval for products, I think it's a matter of us gaining our own experience with the products and which products patients have the greatest access to and we have accessibility to as clinicians.
Thank you, Paul. Another question about FDA's decision to end enforcement discretion for stool bank provided FMT products. It seems to me that particularly since none of the LMTs are available yet, that many people may be stuck with recurrent C. diff. I think I agree. I mean, the fact that we don't have a consistent a product that is universally approved, FDA approved, that can be used. There are a lot of patients suffering out there with recurrent C. diff. And a lot of institutes are not able to do fecal transplants given that the fact that they don't have the product, and there have been reports of ESBL infections, particularly with other products that have been out there. Paul, did you want to say anything on that?
Yeah, I mean, this report came out yesterday afternoon, and certainly it's a little bit head scratching. I think we just need to keep our eyes open and our ears open for what is next.
I think we have answered all of the questions that we've had. I mean, a lot of similar questions out there. I think that we've all answered all of them.
Great, thank you so much. Before I make my closing remarks, I will address the question about getting the presentation. So as long as both of our speakers agree to their distribution of their slides, then the IDSA Foundation is happy to share them with the audience. I want to take this time to say thank you again to Drs. Chopra and Foyerstadt and to our audience for attending today's program, sponsored by our platinum level industry partner, Ferring Pharmaceuticals. If you're interested in listening again or want to share this webinar, the recorded webcast will be available on our website in 2 to 3 business days at idsfoundation.org/your-health. Last but not least, today is Giving Tuesday. The IDSA Foundation would like to invite you to make a donation to our organization in honor of your mentor. The link to donate is in the chat. Our team will send your honoree a thank you e-card on your behalf, and you will both be recognized on our website unless you choose to make a gift anonymously. By supporting the IDSA Foundation, you're acknowledging that this community of specialized professionals needs to grow, and mentorship is a critical segue into the field of ID. So please join us and donate today to honor the person who supported you in your ID career. Thank you all again, and have a wonderful week.